Hi, everyone. If you were watching on YouTube, we're about a couple minutes from going live in front of our Zoom audience. And you are with our esteemed panel and my co-moderator, Gene Ware. So bear with us as we get ready. All right, we will start promptly at the top of the hour. Sherry, you have all the links to the bios ready to go as well, I'm assuming? I'm sure you do. All right, I'm not going to ask.
Yes.
You're a well-oiled machine. I can't remember a time where we were this ahead of schedule and waiting for the clock to turn to 12 o'clock. Really do. Greetings, everyone. This is Eric Laser, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospital systems, and other healthcare-related organizations around our nation. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Now, if you have not subscribed to Bright Spots in Healthcare, stop what you're doing right now, grab your phone, click on whatever your favorite podcast app is. If you've got an iPhone, it's probably Apple Podcasts, maybe it's Spotify. If you're on an Android, Google Play, Stitcher, wherever you listen to shows, type in Bright Spots in Healthcare, and please subscribe. And then within the theme of today's episode, folks, please give us 5 stars on that rating. We are presently at 4.8, and I could tell you the more ratings we get and the more subscribes we get allows your peers around the industry to more organically find the show and gain access to all the tremendous ideas and bright spots shared by our guests each and every episode. We have a super panel planned for you today. And as usual, to save time, we're going to bypass introductions, but we'll post the bios in the show description within the podcast app you're listening to, as well as here in the chat for those attending live. However, I want to introduce you to one person, one of my colleagues, one of the producers here at Shared Purpose Connect, and my co-host for today, Gene Ware. He is returning back to the show. He co-hosted once last year, and we're bringing him back because he did that good of a job.
Well, thanks, Eric. I just want to say hello and welcome, and thanks for having me back. Did want to note, we are not necessarily going to have co-hosts or co-moderators every episode, but we do want to ensure that if in the rare emergency situation that you, Eric, are not able to join, that our audience and our panelists are in great hands.
And I think they will be. Gene, if you haven't met him before, has been in our industry producing and marketing healthcare conferences for over 10 years. So he knows a little bit about our space. And maybe more impressively, at least to me, he's a lead singer of a band. And he's also an actor who's been in television series with some A-listers, which I always find super exciting and impressive. So just for the folks who are into like the society and social stuff on the show, name drop first, Gene.
Okay, so recently I had a scene in the HBO series Julia, which is about Julia Child, opposite the lead, Sarah Lancashire. I also had a great scene opposite our local homeboy favorite, Chris Evans, in the Apple TV series Defending Jacob.
Nice. Gene and I are local to the Boston area. That's his reference. And now you get to co-host a podcast and webinar with yours truly, and we could discuss your career path like offline. I don't know.
Hey, I think it's on the up. So look, thanks again. And it's really exciting to be part of the moderation process, and especially for today's topic, which is mitigating social risk to achieve higher star ratings. First, I do want to give a quick thank you to one of our favorite partners, Socially Determined. They are an invaluable partner to health plans to drive star ratings through their industry-leading expertise, coupled with their super platform, Socialscape. Now, Socialscape empowers health plans, providers, and other risk-bearing organizations to manage risk, improve outcomes, and advance equity at scale. Now, Eric will tell you more about them later on in the show, but you can check them out right now at sociallydetermined.com. Now, I'd like to kick it off by talking about the overall strategy for achieving 4 and 5 star ratings. To start, I would like to bring in Kathleen Faulk, who is the Senior Vice President and General Manager of Government Programs at Regence. Now, those of you listening probably know how much more challenging it is for a Medicare Advantage plan to achieve these ratings if you're part of a payvider model or part of a larger health system. So, Kathleen, what is the star strategy at Regence? Oh, you're on mute.
Thank you, and thank you for inviting us today. It is more challenging, I think, for a health plan if they don't have an integrated model. Our strategy or our strategic objective is to have 4 or more stars, 4.5 stars for every plan that we have. Last year, we did have a 5-star plan, but this current year right now, we have 94% of our members in 4+ star plans. And part of that is because we have a very focused and intentional model of outreach to our members and very focused on the member experience. Our primary value proposition is a model of service. We're a local regional blue, and service is what our members come to expect. So we have many intervention and outreach that's very hands-on, very live, person-centric. While it may be a more expensive model at times, we found that it's worth the money that we spend.
That's great. Could you just as a quick follow-up, Kathleen, could you focus a little bit about with your local focus and your service focus, how important or how intense that is relative to everything else you're doing relative to your star strategy?
So I would say the service first live person model is our foundation. Everything within our star strategy, as well as our general customer service strategy, marketing, etc., is that white glove type of model. And within stars specifically, we have different concierge programs. In stars, listen, this takes everybody in your company to perform. And so as a collective in our organization, we use that service first, take care of our member, help them navigate, live person to person. That is the foundation of how we do many and most of our interventions. We have digital, of course, but we find we have a good ROI also on that person to person contact.
It's great. I want to stay with that theme because I know we're in this world of digital and virtual, and Independent Health, who is out in Western New York, is a 5-star Medicare Advantage plan. And they also go what I call a little bit old school. Old school may be the new school. So I want to bring in Dawn Odzywolski. She is the Vice President of Medicare Programs at the aforementioned Independent Health. Dawn, tell us a little bit about your, what I'm calling, my words, not yours, feet on the street strategy, and how this enables you to maintain such a leadership position, both in market share in Western New York, but also with the star ratings.
Absolutely, Eric. So I'll actually start with a quick little story. Here in Buffalo, we have a lot of pride. We're not just, Bills football fans here. We go way back as a local not-for-profit. And back in 2006, when Medicare Part D started, there was a lot of confusion. And what ended up happening is the community ended up saying, hey, go talk to the people with the red shirts. So we have an apple as our moniker. We wear red shirts. And essentially what became was a theme of go talk to the red shirts because they know what they're talking about. And we actually created that as our brand that we still use today. You'll see that on our billboards. You'll see that in our advertising. But it's way more than just an advertising play for us. it truly is the way that we deliver a service model. So very similar to what Kathleen was saying, in that we really believe that it's about being one-on-one with the person and delivering the red shirt treatment. So during the annual enrollment period, we actually staff up with what we call red shirts. And these red shirts are actually people who are Medicare peers. So they're there talking to people who have Medicare just like them. And we really do feel that it makes a huge difference, not just during the annual enrollment period when everybody has so many questions, but all year long. So we actually use that model not only with the brick and mortar approach, where we use that where you can come, you can see us. We have pop-ups that we during the annual enrollment period when we get so busy that you can come see us, and we do road shows too. And of course, with COVID, we did have to pivot. So we did go hybrid. You can set up a meeting with us that's virtual, whether it be Teams or Zoom, whichever you prefer. We also have chat capabilities. But I'll be honest, those really aren't the ways that people want to work with us. You have very, very little utilization. Everybody really wants to still stick to the face-to-face model, which is why we think we've been so successful. We do see that in our CAP scores. We also see that in our retention rates as well.
Could you give an example? Could you share with me those numbers?
Sure. So year over year, we're pretty proud to say that, we're right around 98%, 97% retention rate year over year, and about 95% of our CAP scores we've earned. So we really left very little on the table in rating of drug plan and rating of health plan in particular. So we really think that's a testament to the service model that we can deliver.
Okay, so I want to break this down a little bit and keep me honest, because I want to make sure we capture all of this. And incidentally, as a quick aside, once we're done with this line of questioning, see if you could change your mic. We hear you, but it's not as clear as I thought you were going to be when we were in our green room ahead of time. But this is what I heard, and I think everyone heard. So these Medicare information centers are a way to almost go with a retail strategy to deliver the red shirt treatment around your market. And what you're finding is you have permanent information centers around Greater Buffalo, and then you also have pop-ups that you're deploying around during enrollment periods as well. And these are not only enabling members to enroll, so it's a commercial effort, but it's also a way to get questions answered as well around their benefits and everything around healthcare. So it's a very and because they're staffed by people local to the community and that neighborhood, it's almost like this come to see your CHW. I know you're not using CHWs per se, but it's just a way to have a very trusting person speaks like me, person knows my neighborhood, and be able to get explanation of benefits. That's obviously driving up your CAP scores.
That's exactly it. These are our neighbors, these are our relatives, our friends, our aunts, our uncles. And we are where they are in the community. So whether that be a strip mall, whether that be a community center, we are present.
And the other thing you mentioned to me in preparation for the show was sometimes you're staffing these with actual Medicare Advantage beneficiaries. Can you talk a little bit about that?
Yeah, absolutely. We do find that the peer model, as we call it, is really quite effective because they can resonate with the questions that the beneficiaries have. And what we find is that they don't feel like they're being spoken down to. They really can understand the situations that our members find themselves in.
Okay, I want a quick PSA. You have a Q&A module there. Everyone who's attending live, you could throw your questions in there. We will try to incorporate them into the conversation, although admittedly we have a pretty jam-packed agenda, and I'll address that later on in the show. I want to bring in Ashley Perry. She's the Chief Strategy and Solutions Officer at Socially Determined. Ashley, how are plans incorporating this correlation between social risk and stars? And maybe you could provide an example for us.
Yeah, so Eric, it really starts with understanding the social risk profile and distribution for your full market and member population. So just to give you an example, one of the plans that we worked with, it was a regional Blues plan in the Northeast, and they were serving a couple 100,000 Medicare Advantage members over a relatively large geography. And so where they started was looking at contours and concentration of community level SDOH risk exposure, as well as member-specific social risk factor scores across their entire MA population. And then being able to correlate that with utilization patterns, historical costs, and STARS attainment gaps across that population, and being able to surface, where do we see the strongest signal between elevated social risk and that suboptimal utilization, excess cost, or attainment gap. And so what that creates for the plan is a really specific roadmap around how they can start to address those social risks and be able to see that pull through to ROI. Just to give you one kind of data point around this. So when we looked at the members who had one or more STARS attainment gaps over the last 3 years, we saw that 78% of those members faced elevated risk for one or more social risk factors. So something like food insecurity or housing instability. In contrast, when we looked at the members who did not have a STARS attainment gap, it was less than 30%. So really big differential there in terms of risk exposure that's pulling through to those attainment gaps. And so it allows the plan to see that for their full member population, and then to think more strategically about how do they deploy the great programs that they have, some of which Kathleen and Don have just been talking about, more strategically across their market and their member population so that they can address those needs and ultimately be able to close the gaps.
Okay, let me summarize that quickly if I can. So it's important from a strategic standpoint to correlate that social risk with STARS and then understand where those STAR attainment gaps are. And I think you used the word social risk exposure, which is that variance between social risk and STAR attainment, and then being able to identify those folks. It's more than likely that the folks where those gaps are at elevated risk for certain social areas.
Exactly right. So you understand the risk profile for your full member population. You understand sort of historical utilization cost, attainment gap perspective. And then it gives you a roadmap to say, okay, if we're going to try and close these gaps, we have to understand how do we address those underlying social risk factors? Because if that's really what's driving the gap, solving that is going to be much more effective than just focusing on the measure itself.
And are there other core components? Like, could you just create the outline for us of some of the things that maybe this audience, they probably anticipate, but like just make it tangible and real for them with the data that you're seeing?
Yeah, so just to give you a practical example, in that example that I was talking about with the Blues plan, so we generate social risk factor scores, food insecurity, housing instability, et cetera, full member population. We look at attainment gaps, and then we start to see certain patterns that are pervasive and persistent across the STARS measure set. So for example, when we looked at members who had a gap around the annual wellness visit, we saw consistently that the most common underlying social risk factor for that particular population had to do with food insecurity. And not just food insecurity, but food insecurity that was really driven by an underlying issue around the affordability of food, as opposed to some of the other components that we build into our food insecurity model, like accessibility of food or food literacy. So it gives the plan a very specific roadmap for not only who is at risk and how that's impacting that AWV measure, but also how do you tee up an intervention that's going to be able to solve that underlying social risk and ultimately close the STARS gap. When we looked at some of the other components within the measure set, we saw that it was different social risk domains and underlying factors that were most impactful. So for example, when we looked at the medication adherence measures, so the cholesterol, diabetes, and hypertension measures, we saw that the social risk domain that was most impactful consistently across those members with attainment gaps had to do around health literacy challenges and housing instability. So it tees up a different series of potential supports and intervention strategies.
Okay, so in summary, I think the two big points that I wrote down: strong signal to strong elevated risk and STAR attainment gaps, and then it doesn't necessarily apply to the same way for the different measure set of SDOH domain sets. Did I say that right?
Yeah, exactly. So think about it this way. You want to take a data-driven analytics first approach to thinking about that correlation between social risk and STARS attainment gaps for a couple of reasons. One, that it varies across the STARS measure set. It also varies across the different social risk domains. And for us, it's socially determined because we've worked with lots of plans around the country. We see that it varies depending on the geography, the specific market that we're looking at, the specific member population. So that's why the data piece of this is so key, is that it will tell you with precision where are you seeing the biggest impact between social risk and stars attainment across your market, your member population? And then how does that tee up for you the most effective support strategy, intervention strategy, et cetera?
I love that. Okay. There's a lot of good questions coming in here. So I'm going to, at the risk of putting us off schedule, throw a couple in over to you guys. So I'm going to come back to Dawn for a reminder of those of you who are joining us late. Dawn Odzywolski is the Vice President of Medicare Programs at Independent Health up in sunny Buffalo. And what I'd like to ask is a couple of follow-ups here. For one, what type of training do those red shirts get? First of all, Dawn, and then how do you reduce that voluntary disenrollment in the 90-day window that the individuals have to opt out to another MA plan or a fee-for-service product?
Sure, those are absolutely great questions. So simpler one, the red shirts, they do get about 30 days worth of training before we let them hit the ground rolling. We start that training in August. So really we ramp up during the annual enrollment period, which effectively starts on October 1st. But we're working with them, we're training them. And actually we have so many that come back year over year that they understand Medicare really well. So we don't have to cover the basics with them year over year. So it's probably the simpler question to answer. To address the 90 days, sorry, there's a dog in the background, if you hear that. To address that 90-day retention, we really don't see a problem with that. Although we do have a very competitive market, unfortunately in our area, we have 86 different plans that beneficiaries can choose from. We see very, very aggressive marketing tactics. We do make sure that we put a lot of time and effort in terms of that member onboarding experience. So we make sure that not only after they submit the application to us, that we're working and reaching out to them to make sure they have continuity of care needs. But in addition to that, we're sending them material to make sure that they know how to use their benefits too. They've got a lot of great supplemental benefits.
Can you repeat the last sentence one more time? I lost you there, Dawn.
Sure. So making sure that they know how to use their benefits. So making sure that they're getting their member guide so that they understand exactly how to use their services.
That's great. Okay. I'm going to do one more and then I know Jean's chomping at the bit to ask Dr. Kloepfer-Shapiro a question here. So I think this is to you, Ashley. I'm going to try to factor in two questions here. So one, are you going to, can you share what SDOH risk screeners you're utilizing, and are you correlating functional and cognitive status with SDOH to attain risk scores? And then how are you determining correlation versus causation for social risk factors and the impacts that these make?
Yeah, so really important clarification here, Eric. We're talking about correlation, not causation. It's important for everybody to realize that. And then secondly, on the screening question, we're actually not using any screeners at all. And that's important for a couple of reasons. First, it allows us to create consistent risk scores for an entire member population without having to have any direct engagement or interaction with them. And that's helpful because it gives the plan like a complete view for the entire population. It's also helpful because we've seen, with some of our analysis we've done of screening data, that it tends to systematically miss populations that are more vulnerable because they're disconnected from care. They might be unlikely to respond to a survey that you mail to their home. You might not have their correct address, et cetera. So it's an analytics first approach to generate risk scores. It's not self-reported social needs given a response to a point in time screening question. And so it allows you to have a more complete view for your population, and it allows you to do it in a way that's sort of driven by an equity first lens.
Great job. Great. All right. Before we get to Dr. Kloepfer-Shapiro, I want to let everyone know, if you haven't heard yet. So we've been doing this show for a long time. We've gotten a lot of feedback from you, and we are going to do something we've never done before this summer. And on August 24th and 25th, we're going to host our first in-person event. We are calling it a Payer and Provider Roundtable, and we're entitling it Whole Person Care Innovation, Bright Spots in Clinical Models and Consumer Engagement, August 24th and 25th in Boston on the shores of the Boston Harbor at the Marriott Long Wharf. And there's going to be a huge theme here tied to social determinants of health, access and equity, how to engage. And then we're going to go one step further and talk about the care models to best put in place for solutions and then ROI modeling. Now, here is why this is going to be super unique. It's not your typical conference. I know many people have a lot of conferences they're going to over the next 6 weeks. This is going to be for payers and providers and CBOs only and some select sponsors. So it's going to be small. That's number one. Two, and this is sometimes this is shocking to people, there will be no presentations. We have no presentations or PowerPoints. Each of the 5 sessions are going to be launched by a roundtable, just like the one you're looking at today or listening to today, live though. And then we're going to break out into facilitated roundtable discussions for everyone participating. I'll have a trained facilitator at each table, and we're going to have group discussions and then report outs on each topic that we intend to cover over the day and a half. That way you get a chance to network, have conversations with, and share solutions and bright spots with almost every single person in attendance. So as a leader in your organization, when you spend expense budget, travel budget, to go to these conferences, it's so important you come back with exceptional ideas or new strategies that are being deployed around the country. This is going to allow you now to come back with new ideas and enhanced thinking much more easily than some of these large conferences. So we are excited to be doing it. You could register and check out the brochure and some of our confirmed panelists. I've already confirmed a half dozen of exceptional folks from payers. In the links to both the podcast and the chat here for the live attendees, you can check out the brochure and register at a very special pre-registration rate right now. So hope to see you in Boston on August 24th and 25th.
All right. It's my turn. So, hey, I have the distinct pleasure to bring in Dr. Angela Kloepfer-Shapiro. She is the Regional Medical Executive, Northeast and West Regions at Cigna Medicare Advantage. Angie, welcome. And you've been incredibly patient. So I'd like to ask, what is an example of a program that Cigna is scaling to specifically target social risk and drive higher customer satisfaction numbers?
Yeah, thanks, Jane, and thanks for having me here today. This is exciting. As an internal medicine doc, I take care of and have taken care of a lot of seniors over 65, a lot of Medicare beneficiaries. And the thing that makes me so excited to be a physician at Cigna MA is that I can then be part of these types of solutions, and I can talk about them today. So thank you for having us. The key point about our strategy and making sure that we're addressing things and that we're using our supplemental benefits so that we can move the needle on social risk factors and mitigating them is why I'm here, essentially. So I've got 2 programs I want to talk about. The first one is our Cigna Healthy Today card. So this is available to all MA customers at Cigna. Essentially, it is a Visa card. It's a prepaid card that we load with dollars that are based on the benefits that a given customer has, including allowances for, things like OTC, access to OTC products. They can use them for healthy foods. So healthy, purchasing healthy groceries, fitness classes, fitness programs. There's a pet allowance in some of our benefits. So all of these get at some of our biggest social determinants of health. So loneliness, food insecurity. We have an allowance for utilities. So things like housing instability. Ashley, you mentioned something about correlating the housing instability to performance in some of the Part D measures. That really resonates, and I think that's huge. So we're using this card right now. We fund it annually and in some cases quarterly. It's a brand new benefit for our 2023 benefit year. And so it just went live January 2023. But in January alone, so we do have January data, I'm pretty excited already just seeing how our customers are using this and how it can inform where we go in the future. Just some high level numbers. So more than $500,000 has gone towards customers' utility bills. That says a lot. That says a ton. $3 million towards healthy foods, $7 million towards fitness activities, and nearly $10 million on OTC health-related items. That's just in January. So I'm super excited. Can't wait to see what we learn from the utilization of this and where we can go in the future. I want to bring up one other thing. So mentioned I'm a doctor, internal medicine. You know, my life is in the exam room, in a clinic, in a hospital room. Medicine is individual. We cannot escape that. When we're working for a big company like Cigna, big MA plans, we can't forget that all medicine, no matter who's providing it, is individual. And I consider the payers, we are doing some of this work to help our customers. So let me bring it home a little bit, also back to that old school model that Eric referenced. So we have a team of registered dietitians that work at Cigna MA. We launched this program late last year, so in November of 2022. So these individuals work hand to hand with our customers directly over the phone, coaching them on things like weight loss, making healthy food choices. We've already had about 500 customers just since November take part in this. 63% engagement rate, which is pretty good, you know, when it comes to clinical programs. And we already have just a quick anecdote on one customer who's really enjoyed this. She's lost 11 pounds. She now works out 7 days a week. I want to read a quote from her. "I reach for fruit now and not pie. I drink only 1 soda a day instead of 4. I've seen it as a doctor. Little changes like this make the difference."
Love that.
Wow, that is amazing. What a great testimonial. Exciting stuff going on at Cigna. That's great. I would like to move over to adherence, talk about and hear some stuff about adherence. Kathleen, if I could swing over to you. Kathleen Faulk over at Regence. Can you let me know, how is Regence tackling medication adherence?
It does, as Angela said, and even Ashley, adherence is inhibited by social risk factors, right? The cost of food, the cost of medicine. And so we use a process where we're trying to identify those risk factors and have found that we've had effectiveness with our pharmacy coaching process, and it's pharmacists, not just techs. And for us, we're continuing to evolve this because we find that when a pharmacist is engaging with a member, and especially when they have social risk needs, there's a lot of credibility that comes from the pharmacist, right? And it's for the chronically non-adherent, we partner up a pharmacist that will be able and specializes in their issues. It's largely telephonic. We do use text and SMS to get the appointments made, but the pharmacist talking to the member is really a great way to confirm their social risks. And that's the problem that we're after. The pharmacist can then work with case managers, et cetera, people in customer service, so that we can connect this member to services that are available to them. And there has to be unique outreach. We don't use the pharmacist model for every member, of course, right? There's just not an ROI on that, and it doesn't make sense. But where it's a need, the pharmacist direct model goes back to that service is the value prop we offer. It's been very effective.
Love that. Kathleen, a quick follow-up. I don't want to put you on the spot here, but and if anyone else wants to jump in, I'm hearing a lot about like old school human beings talking to other human beings. And I know how important that is. Is there any financial models that are justifying all this? Star ratings is obviously so important. Is that what's driving this? Is that big drop from 4 to 3.5, or are there some other financial models that are actually sending signals to your CFO and your CEO that this is worth all of that?
Well, I'll jump in there in the beginning. Yes, there are financial models behind our decisions. We have to be prudent fiduciaries with the dollars, right? And as long as you can identify the right members to spend the high touch model on, it is stars that helps pay off. That cliff between 3.5 and 4 stars, that's significant money. I mean, it represents 4 or 5%. That's an entire profit margin and more. So it is a main driver. The other driver, especially in adherence, is the cost of care for certain chronic conditions. that you really need them taking their medicine. Diabetes is a perfect example. Diabetes is the gateway disease to many other chronic conditions. And so if we have adherence in diabetic medications, it can definitely pay off. And we use strict, has to be real dollars to pass our CFO appropriately. And we have ROI models that support this.
Yeah, great.
How about others?
Look at Kathleen now co-moderating. Gene, we're
sorry, I just
I'm out of a job.
Jump in. So
I agree. I'll pause for a second to see if anyone else wants to jump in.
So Kathleen, I wanted to ask you a follow-up on that. One of the other things we've seen with a lot of the plans we've worked with is that engaging around helping address members' social needs also has a material impact on member retention year over year, particularly among first-year members, right? If you can identify their social needs early, you get them engaged around meeting those needs, they have a much more favorable view of the plan and are more likely to stay. And then if you can keep them for 1 year, you can keep them for 5, What have you seen on that front? And is it making a difference in terms of your retention members as well, or retention numbers as well as the adherence ones?
we have very high retention, 98%. And we attribute much of that to our high touch model. But also, if you can meet a member's need, yes, they're going to stay with you. We do a lot of this in collaboration with our provider partners. Obviously, it's not just the health plan on its own. And so we do find that we have more retention. I can think to a couple of examples where members in their first year, the latest data we had last year is that half of the members that left us were in their first year with us, right? And so securing them in that first year is critical to make up for retention costs. Identifying them early, we use external data on, Experian as an example to help hone our identification and risk modeling. We have to augment that with our own AI. But if you can reach these members and help them through that chronic condition that is based in a social issue, they will stay. Yes. I haven't run specifically the retention because if overall is 98%, that's pretty high to begin with. So maybe those that we reach out to, could be 99 point something. But when half of your members leave in the first year, half of your leavers are members in their first year, this reach out's critical.
And the early part, I think, is key, right? So being able to understand social needs, as soon as they enroll in the plan and not having to wait to have that claims history available really provides an advantage so that you can drive that early engagement and get on the path to retention.
Yep.
We, one of the things, and thank you, a lot of questions coming in, folks. I appreciate it. We're trying to get to as many as we can. We constantly listen to your feedback, and incidentally, you're going to get a survey asking how we did on the show, how Gene did on the show in about 10 minutes. So please check your inbox and take that survey for us. We listen to all of it very closely. One of the biggest criticisms that we get about this show, especially from our live attendees, is that it's too short. And I just don't think expanding it to 90 minutes will expand our audience. I think it'll be more challenging for people to come. But what we're going to try to do, because I know the complaint is we don't get to everyone's questions in time, we're going to do something a little bit different. We're going to pilot something for this show. And so on Monday, March 13th, we're going to have a fireside chat. We're going to do 2 of them, one at 8 a.m. East Coast time, and the other for some of you that want to have a slower morning at 12 p.m. East Coast time. And the purpose of that fireside chat is to have a 2-way Zoom call to answer many of your questions that you didn't get answered today. So I will be moderating it. I'll be joined by Ashley Perry and hopefully others, and we're going to be able to try to address many of the questions we don't get to today. So if you want to come to one of those, our producer Sherry Keel is going to put up a poll and ask you which one you want to come to. And if you don't, that's fine too. But this could be a way of making sure we get everything answered and augmenting this session on Monday, March 13th. I hope I said that date right originally. All right. Also, we can't do all of this without the support of our great partners. And I wanted to give another shout out and thank you to Socially Determined, who's been one of our best partners over, I don't know, it's been like 15, 16 months now. And if you didn't catch us at the beginning, they are the leader in the transformation of healthcare delivery and payment through social risk analytics and solutions. They have this innovative, unbelievable platform called Socialscape. It's a SaaS platform, and it allows and empowers health systems, plans, and other risk-bearing entities to best manage risk, improve outcomes, and advance equity at scale. They were recently named by Fierce Healthcare as one of the 15 most promising healthcare companies. I'll double down on that. And we're excited to have them and folks like Ashley participate in our programming. So thank you to Socially Determined. You can check them out at sociallydetermined.com. I want to stick with medication adherence and bring back Angie into the conversation. Angie, we just talked about sort of how the pharmacists from at a Regence have been financially justified to making a lot of outreach calls and talking directly to MA members. What are you guys doing around medication adherence and leveraging your pharmacists?
Yeah, thank you. So, first things first, similar to Kathleen's program at Regence, we do something very similar with medication adherence calls. We know, this is such a critical topic. So for individuals over 65, the average, more than 50% of them, so actually more than 50%, take 4 or more medications. So I know as a doc when I was practicing, and now even more so, that keeps me awake at night, that they're taking that many medications and many more in some cases. And then how do they even know, again, back to kind of some of Ashley's points, how do they know what they should be taking and if they should be taking something? They get so much variable information out there. So we absolutely have a program. So we reach out to customers who, using our claims data, our pharmacy claims data, who haven't filled a medication, who are at risk for having a poor outcome with their diabetes, with their heart failure, with their hypertension, because they're not filling their medication. We have, again, these are warm, one-to-one phone calls. So back to that old school model, they're having a conversation with the customer, asking them, are there any barriers? Is there transportation? Are you having financial issues? And if they are, one of our prime focuses right now at Cigna, and I think I hear this at a lot of different places, doing these warm handoffs. If they're experiencing something, reach out to the case manager who can help them connect with a resource locally, reach out to a social connector, one of the companies that we partner with to help make things accessible, make sure they're getting things delivered at home. That's critical. One question or one aspect of this I want to bring up is, how do we reach people, right? We know sometimes it's not easy to reach customers. Sometimes, I don't know about you all, you get a call on your phone, you don't know who it's coming from, you're going to let that go to voicemail because it might be spam. So we have mobile branding so that customers know it's Cigna calling, right? There's something going on, like this is your health insurance company, pick up the phone. So we have that. We also partner not only with physicians and of course the prescribers who have a clear vested interest in medication adherence, but also the retail pharmacies. So we have partnerships with many retail pharmacy firms to make sure that we are all three working together, the pharmacy, the provider who wrote the prescription, and us at Cigna, to get to make contact with the customer, especially one at risk, and making sure we impress upon them the importance and make sure we're addressing medication adherence. 34% of the customers that we reach out to, medication adherence is the topic that our pharmacists and pharmacy techs are having with them. We last year made 1.3 million interventions with customers. So an intervention is, do you know why you're on a statin? Oh, here's why. This is why. That's an example of an intervention. Education. Is it closing a gap? Something like that. The average time to finding the best outcome for a customer is 1 day. So these are rapid turnaround as well. Really important topic.
Wow. That is great integration and tactics for adherence. The turnaround alone is motivating. I do want to swing over to Dawn, if I can, for the next topic. Dawn, it's a bit of a two-part question, if I can. We're talking about benefits and incentives as core levers plans have to drive positive behavior. How is independent health thinking about plan design as a part of your overall strategy? And how does this approach mitigate social risk?
Absolutely. So we were really thrilled to see a couple of years ago when CMS started to give more tools to the plans to be innovative. We've been saying for years, we know we can do more, please let us. So a couple of years ago, when the special supplemental benefits for the chronically ill, or as we say in the industry, alphabet soup, right, SSBCI, came out, we kind of sat back and we watched a little bit to see what other plans were doing. But we went and jumped all in a few years after it was announced as a tactic plans could pursue, because we really felt like having these special supplemental benefits, which essentially allow you to tailor a copay reduction, for example, or through something called uniformity flexibility, to tailor a reduction in copay for individuals who have a chronic condition, or to, for example, give them a benefit that they otherwise might not have available to them in a standard supplemental benefit offering. And by doing this, we really felt like we've been able to address one of those key issues, which rightfully so is economic, right? In terms of addressing adherence. So a simple example of one thing that we did was to remove the copay for an endocrinologist for a diabetic. Those copays, for example, can be very high. And if seeing that endocrinologist is really going to be what it takes to get that A1C under control, we really felt like that was a very simple step that would have strong return on investment at the end of it. So we've done that with a number of chronic conditions, and we've really started to do that a couple of years ago, and we are now at the point where we have enough statistically valid data that we can start to do some analysis off of it. We're just not quite there yet in terms of being able to share it, but as far as the market and the perception, we know that it's paying dividends in terms of building that trust, getting the members engaged, and that's really what makes a difference at the end of the day.
Could you provide some examples of what those supplemental benefits are? Let's give one example around diabetes, one around we'll call it social determinants, one around at home, and then one around maybe pharmacy, if I could. Sure,
absolutely. So I think the best example is that endocrinologist for our diabetics. We have a number of diabetic programs in terms of virtual, in-person. We have a wealth of diabetic tactics that we use because, as one of the attendees asked in the question, that's a tough population and there's a lot of social determinant needs. One of the other supplemental benefits, though, that we really do feel has made a big difference and we've learned a lot about is around post-acute meal delivery. Post-acute meal delivery is one of those benefits that we leverage that SSBCI model to offer. We were worried about the cost, of course, so we wanted to try to limit the exposure, at least when we were first kind of getting our feet wet with that. And what we learned is that it's not just about offering the benefit, but it's a lot more about bringing the benefit to the member at the right time in the right place. So when we first offered the benefit, we were in single-digit utilization. It was pretty crazy. And we were so disappointed because despite our best efforts, training our discharge planners, training our case managers, getting all the information out in front of the members, nobody knew they had the benefit when they needed it. So how can you provide an effective intervention on this SDOH area if the members aren't actually using it, right? So what we did is we started to use our admission, discharge, and transfer data that we receive as a health plan. And essentially almost at the time of admission, we were creating a letter to send to the member that would be in their home at the time that they entered. And they said, well, what am I going to do for food? They might have special nutritional needs. So we work with our local Meals on Wheels provider to provide an in-home safety check at the same time as providing them a nutritionally appropriate and calorie appropriate meal so that we could prevent that readmission risk. And what we then find is that by building that trust, and as one of our other panelists said, that we can actually engage them into all of these other programs that we have to offer. Many of them even stay with the meal delivery program because they're qualified for Meals on Wheels in their community, which is so great to see because we're keeping them in their home safer and longer in the long run. And last question, Eric, and I know we're getting short on time. You did ask about the pharmacy, a little bit different of approach, but we did a couple of years ago, and actually I can say this was a testament truly in terms of us being able to earn our 5-star 2 years ago. We're proud to say that we've hung onto it for 2 years now. We were looking at those CAP scores and seeing the issues we were having with rating of drug plan. And we said, we've tried everything. What else could we possibly do? So as we were preparing our bid and doing our benefits, we made a very concerted decision to reduce the deductibles on our Part D plans. And after that, the year that the star ratings would have hit 4, we actually did see our 5-star change. And I'm sure there was a lot of other things going on at that same time, but we really do believe that that was very effective in improving that rating of drug plan score, which eventually earned us our overall 5-star. So a lot goes into the plan decisions.
Yeah, that's great stuff. Got the questions reported in. We'll hopefully try to address a lot of them on Monday, the 13th. We have 2 shows that we are live recordings. We are presently finishing up final touches on that are related to this topic. We're going to talk on March 16th about how virtual care enrollment and engagement and helps with aging at place. And we're going to have UPMC Health Plan, another 5-star, Highmark, and Oklahoma Complete Health, which is a subsidiary of Centene. They're all going to be on the show on March 16th. And then the following week, we're going to be covering CAPS and through enhanced benefits navigation. So if you want to come to either of those shows or both, Sherry Keels will register you if you want. So she'll put up a poll for that. Ashley, let's talk about what folks are doing wrong. I know a lot is a lot of these tactics and programs we're hearing about and the strategies are driven by data. That's not breaking news, but what are health plans doing when they grab that data that maybe aren't as effective as they need to be in delivering the right services to the right people at the right point in time?
Yeah, Eric, so I'm going to take the liberty of reframing the question a little bit and say not so much what are plans doing wrong, but what could they potentially be doing more of? And some of this is an extension of Dawn's comments, but so thinking about social care interventions, what plans are doing right today is they're taking a really data-driven approach to designing those interventions. So there are lots of plans like those represented on the panel today that have these really data-driven, evidence-based, tailored social care intervention programs that they've either developed internally or partnered with local CBOs or other intervention solution providers to be able to deploy. All of that is great. I think where there's more opportunity is around pulling that data-driven approach into the intervention, deployment, and engagement strategy. So right now, we're kind of taking collectively the if you build it, they will come strategy, right? We stand up these programs and we hope they find their way to the members that would benefit most from them. If instead we leverage social risk data and analytics to proactively identify those members that have unmet social needs that are uniquely able to be met by these interventions that we've designed and invested in, I think we can be a lot more effective, both in terms of getting value out of the investment that we're making in all of those interventions, being able to improve outcomes for members, and ultimately being able to demonstrate that those types of programs do pull through to ROI. So it's just an extension of the work we're already doing around the design and implementation piece, but it's really taking that data-driven approach to the enrollment and engagement component for those interventions as well.
Could you quickly provide 2 examples just so it's crystal clear what you mean by that?
Yeah. So let me give you one from, I'm sitting here in DC today, so I'll give you a local example. We were working with a plan here in the district that had a great portfolio of 15 different social care interventions, some of which they had built, some of which they had partnered with local CBOs around. That was all great, but when we looked at the historical enrollment data for those interventions, what we saw is systematically they were missing the subset of the broader member population that would benefit most from them. So even though they were able to demonstrate ROI and they were moving the needle around lots of important metrics, both around utilization and quality measure attainment, they were actually blunting the impact of the intervention because they just weren't proactively getting it to the right subset of the members. So they used our social risk factor scores to identify and match which members have which needs that can be solved by which programs. And then they engaged in proactive outreach and engagement strategies around being able to make that connection. So it was the same work that their team was already doing. It just wasn't informed by that view of their members' social risks. And so there was just a missing piece of the puzzle.
And a quick example, and I know you provided one earlier, but just another quick example, like transpose that against one that's killing it, doing it well.
Yeah, I mean, so that same plan, as soon as they had the social
Once they
risk
switched it.
factor, yeah, they were able to do it. And then it was amazing. So then you see, interventions that were already, for example, reducing like low acuity ED utilization or potentially preventable admissions by, let's say, 10 or 12%. Suddenly that jumps to 35 or 40%, right? That's huge in terms of the ROI for the dollars that the plan is investing in those interventions. And it pulled through to other things like I asked Kathleen about earlier around retention, satisfaction, engagement, et cetera. So lots of benefit to be had there by just taking a little bit more of a data-driven approach around not what interventions you stand up, but who do you try and get engaged in them.
I want to quickly shift gears. I don't think any of this works if we're not getting innovative in how to engage and incentivize our providers. So Kathleen, how are you guys engaging physicians in all these efforts?
It's many of the standard tools and outreach, but here's what I would add. We have strategically decided to have a robust or generous provider incentive plan and strategy. It's higher payout than the average in the industry. There's many reasons for this. We're not an integrated plan, and so we need extra incentive for our providers to do new work to them. I mean, look at the advance notice and what it's requiring of health plans and stars in order to hit the 4+ stars. It will require that we work more with our providers, and this will be new work for them. So I would say our first objective is to have more money thrown at it. We still maintain an ROI anywhere from 4 to 6 to 1, which is a strong ROI because it really does engage the providers, this payment. I think it motivates everybody, let's be honest. But it gives us more time in their mind share time, right? For them to do activities that we need.
And Angie, how are you along those lines best educating your peers in all these efforts so that they, a lot of doctors just haven't had time to really, they don't know what a Z code is. Like, how are you engaging them from an education standpoint?
Yeah, love that. So, 93% of patients surveyed said that their doctor should ask about access to meals. And then one other stat, sorry, I hate throwing stats at people, but 83% state safe and stable housing should be discussed with their doc. So you're 100% right. We as physicians, we see this every day. We know that it's happening, right? We know that people are not getting their optimal health outcomes because of what's happening in so many other facets of their life, but we often feel we don't really know how to address it, short of, oh, here's maybe a referral to this resource. So what we designed an educational program. We have it's essentially a webinar in its current state, and physicians can attain and providers can attain continuing medical education credits. So we aligned with the AAFP, the American Academy of Family Physicians, to make this available. So they get one credit for that, which is nice. We have to keep doing these things. And it's really good. It teaches the difference between health equality, health equity. What are the social determinants of health? And more critically, it gives a toolbox to physicians, to physician extenders, as to how they can implement some of these interventions in their own practices. So we give them 3 different screeners they can use: the Prepare tool, the CMS tool. There are other tools that can be used to just simply screen. How do we embed a screening process into our day-to-day workflow? Once we know where a subset of our patients have unmet needs, what can we do then? So we give an example in this training as to how they can actually implement initiatives in their own clinic, and then, look at the outcomes and measure the outcomes. So it can help them in a lot of different ways. You mentioned Z codes. So we have education and training on Z codes and how those can be used by even non-clinicians in the practices to, help gather information on who is at need of, any sort of social factor. So that's what we're doing. We've had a number of providers over the last year use that, and we'll keep pushing that training out.
All right, let's close it out. Final thoughts, Ashley, about just overall CMS requirements tied to SDOH and STARS, and how should we be planning for sort of the digital education, social care, and equity in general?
Yeah, so I think about this both as sort of the macro trend and the micro trend. So in the context of Medicare Advantage specifically, or the more micro, in the proposed rule, we saw the introduction of the Health Equity Index, which would go into place in 2025. This is the first time that there would be embedded within the financial incentives in the model, a direct reward for plans that serve historically underserved and vulnerable populations. And so in the proposed rule, we'll see what makes it into the final, but those populations would be defined as those who are either receiving the low income subsidy or those who are duals. That all is a strong indication to me that CMS is going to continue down the path that they've articulated around directly embedding health equity into all of their models. And that's consistent with what we've seen with the introduction of the ACO REACH program, which launched on January 1st of this year. It's consistent with what we've seen with the adjustments that were made to the Medicare Shared Savings Program, benchmark adjustment around health equity. So I think it's all just further confirmation that CMS is committed to addressing health equity into all of their programs and doing it in a way that's not just a requirement of the program or a potential consideration for those who apply for some of the voluntary programs like REACH, but also it's going to be a requirement with real, financial hooks embedded in it. And so plans should really spend time now building those social risk data strategies, those health equity plans, so that they're prepared to succeed as we continue down this path.
That's great. For those of you to get your questions answered today, I hope you could join us on Monday. If you're listening on the podcast, it strikes me I didn't give you a way to come to our fireside on Monday and the 13th. Why don't you email our producer, Sherry Keels at skeels@sharedpurposeconnect.com, SKEYLES@sharedpurposeconnect.com, and we can get you registered for that. I want to thank our incredible group of roundtable experts, our panel, for the time and effort you all took to prepare and participate today. Thank you to Jean for co-hosting and moderating. Great job. My message to everyone: use the strategy of looking for bright spots, things working well among all the chaos. These tactics often generate progress and an entire solution strategy to your toughest challenges, like increasing star ratings. And I hope you use the bright spots shared today to maybe inspire your thinking, enhance your company's current approach, maybe to improving healthcare for all Americans. I want to thank you all for listening. This is your Bright Spots in Healthcare podcast. Take care, everyone.